After did an interventional neuroradiology fellowship at New York University under the tutelage of Dr. Alejandra Berenstein. Dr. Nelson has directed the combined neurology, radiology, and neuroradiology residency training program at NYU in the past, as well as was the director of the interventional neuroradiology service up until 2022. Dr. Nelson is quite involved in medical device development, specifically endovascular devices, which we'll hear a little bit about today, as well as he's widely published in many peer-reviewed journal articles on cerebrovascular disorders. We are truly excited to have a legend in the endovascular world, and excited for his talk today on endovascular management of cerebral aneurysms. Thanks again, Dr. Nelson, for joining us, and you can begin sharing your screen.
Thank you. Okay. All right. Am I live?
You just want to switch your view. If you, right above your slide, there's 3 things. One of them says display settings, and there's a little caret next to it.
Yes.
Yep, hit that.
Okay.
Click on the little caret. Yep, and then swap presenter, that first option there. Click that.
Oh, okay. Perfect. Now I gotta switch my camera.
Maybe try hitting that one more time. Or,
Swap. You want me to swap again?
Yep, hit that button. Double click that.
Did it work?
No.
Hold on. Shared window is closed.
Are you working with 2 screens?
It is, yes, I have 2 screens.
Okay, that is perfect right there.
I just have to make sure this is the right talk now, though.
Yeah. That's perfect.
Okay, let's see. Can you see the mouse?
Yes.
Yep.
Great. Thank you.
Okay, well, thank you very much for inviting me. It's a pleasure to be here, an honor to be here. By the way, parenthetically, I got started in pipeline, which will be mostly the address today, flow diversion, early on in the experience collaborating with Cameron when he was at Barrow. So we have a lot of shared experience in this, and it will be interesting to see if we're kind of going in parallel pathways. But the topic today, it's a little bit more aggressive than is customary for me to talk about how flow diversion conquered the world, but I kind of ripped that off from my vascular surgical fellows, colleagues who are constantly talking about EVAR and how stent grafting sort of like changed the world for vascular surgery and the aorta. And there are many parallels because when I first came to New York a number of years ago, my introduction to vascular remodeling for the treatment of aneurysms was Juan Parodi's address in 1991 here at more or less what became the VEITH conference or the AIM conference. in New York, which is held annually. He was collaborating with Frank Vieth at the time at Montefiore, developing stent grafts for the aorta. So without much ado, let's get started with approaches to treating aneurysms. Obviously, there are a number of historic approaches, and that's always constantly being refined, but they do share one thing in common. Basically, they all seek to improve the natural history of the disease, reducing the risk of subarachnoid hemorrhage, rebleeds, mass effect symptoms, or thromboemboli from giant aneurysms. And they seek to do that as uneventfully as possible. So basically, we're trying to balance the risk and of the disease to the risk of the treatment. So there are a number of tools, but when I got started back in 1991 in interventional neuro with Alex Berenstein, there was basically one thing that we could do, and that was essentially deconstructive approaches for certain types of large mass aneurysms. And this is one of those examples, was a large cavernous segment aneurysm in a relatively young physician, a young man that suddenly developed diplopia. And so you see this large cavernous aneurysm here on the T2 weighted images. Here's the angiographic evaluation of it. And in patients who had adequate collateral circulation, in this case through the circle of Willis, through a PCOM and the ACOM, you could basically sacrifice the aneurysm and the parent vessel that it arose from. And in those days, we were using these detachable latex balloons, and you see two of them here. The second one placed to prevent the first one from accidentally deflating and embolizing into the head, which happened occasionally, and occasionally would complicate the procedure. So this was basically the approach. It was a very satisfactory approach for the right person, but not everyone has an adequate collateral circulation. And so in situations like this, where you had a complex aneurysm and the patient did not have sufficient collateral circulation, usually we would combine that with a surgical bypass done with an open surgical colleague to provide supply to the affected distal territory. And then we would sacrifice the vessel secondarily. And that had to be timed properly to keep the bypass open and all of these things. So there were treatments, but back in the early 1990s, things changed. Instead of just doing deconstructive procedures, first, there was a couple of efforts in free-floating coils and detachable balloons in aneurysms to try to reconstruct the parent vessel and address the aneurysm more directly. But in 1991 in this country, sort of a revolution happened, and that was an electrolytically detachable coil. So you had a very fine, soft coil made of platinum so that we can visualize it under radiography. And that was attached to a mandrel by an electrolytic junction, and that could be separated at will and controlled by the operator, which means that you could deliver a coil and retrieve it if you didn't like the placement of it. And that was kind of unique. But equally important in that early stage were the development of accessory tools, microcatheters, support catheters, that enabled two things. One, for us to access aneurysms, and then actually, once we were in the aneurysm, to do something that was somewhat effective. And so that was really kind of the revolution that happened with the Guglielmi detachable coil. Now, there are a number of studies over the course of time which supported the utility of coil embolization of aneurysms, most notably the ISAT trial, and then followed by the Barrow, the BRAT trial, which Cameron was intimately involved with, that essentially reproduced quite dramatically closely the results of ISAT in terms of the effectiveness of coiling ruptured aneurysms versus open surgical approaches. And then in for unruptured aneurysms, there were several studies, mostly large analyses of data that was in the national database, in-hospital database, that just evaluated relative outcomes with coils versus clip for unruptured aneurysms. The problem is quite early on, with coil approaches to aneurysms, endovascular approaches to aneurysms, we found out quite quickly that there was a problem. And the problem primarily related to the recurrence of aneurysms. And this is just an example, a large ophthalmic aneurysm. This, I think, this aneurysm had been treated 3 times. So this is essentially the composite of 3 coils plastered up in the dome of the aneurysm. And you can see the base of the aneurysm here has completely opened up again. And there's effects of that. So it's not just that there might be a rupture potential, because we know from the long-term follow-up with ISAC that occasionally with recanalization of aneurysms comes a renewed risk of rupture. But also with the growth of the aneurysm, patients can suffer from mass effect. And you see the edema here that is affecting the temporal lobe. I think this lady came in with worsening. She already was blind in one eye, but now it was getting into the chiasm and started to have some visual issues with the contralateral eye. The group in Montreal had put together a large study looking at this, and they suggested a couple of things: the aneurysm size and also neck size that affected that prospectively kind of affected the outcome, the prognosis of coiled aneurysms. And this is just another case kind of illustrating 2 things. One is that this wasn't only true of just coils. This is an aneurysm, a basilar tip aneurysm that initially was clipped. You see the clips have migrated with the initial coil mass that was used to treat the failed clipping of this aneurysm. And now it's recurred here. It was treated again secondarily at this time with another coil mass. And then you see this coil bundle here, but there's a recurrence at the base of this aneurysm. And so these kind of failures were like a little bit disappointing, and slowly kind of became called for improvements. The initial improvements involved a number of modifications to coils. Basically, they would be covered with a variety of things, coatings that would hopefully increase their effectiveness, or their filling. Sometimes intrasaccular liquid embolics were also attempted. But more or less, even though there's been a lot of justification of this and retrospective analysis to suggest that there might have been minor effects with some of these things, most of the studies from MAPS to the Cerebral coil or HELPS trial basically showed futility in this, sort of, as they say, basically they were somewhat equivalent. In addition to attempts at modifying the coils themselves, there were attempts to try to change the procedure to improve the coiling, because it was noticed that the aneurysms that were more densely coiled had a somewhat better likelihood of not recurring, given it was a reasonably small size. So balloon-assisted techniques were introduced first by Jacques Moret and then others. Stent-assisted techniques came along in the genre, and then neck protection devices finally, to try to improve the coiling of aneurysms. And this is just one of the first cases, one of the early cases that I was doing with balloon. You can see a large ophthalmic segment aneurysm. This is looking down the barrel of it, inflated the balloon here. And what I learned from this experience was that, yes, you could make the coiling a little bit more effective, not spectacularly more, but more effective. But it kind of clued me into the morphology of the aneurysm neck and the concept that Pietro Lillich had talked about for a long time, that this was maybe some sort of segmental disease, but not just segmental in the linear length along the vessel, but also circumferentially involving the vessel wall. And so when you understand that, it's difficult to see how you're going to arrive at a coil solution, an endovascular solution, or, in fact, even how clips might work to reconstruct that without compromising the vessel lumen. And so understanding that led us to start thinking about maybe a different way to address aneurysms. Instead of looking at the sac of the aneurysm as the target, we want to look at the deficient wall and perhaps place something there that can reconstruct that deficient wall to end up with a vessel reconstruction. So I mentioned that when I first came for my fellowship, I was introduced to Juan Perotti in turns out that there were actually a couple of guys, one in the Soviet Union, this guy, Nikolai Vodoros, who was working in Kharkiv at the time in Ukraine, in the Soviet Union. They were independently working with similar ideas. And the idea was basically to sort of segregate out or address a fusiform aneurysm of the aorta with an endograft. And this was Nikolai's first case. He published it in 1987. This is a device that he handmade to treat this aneurysm, and this is the early result with that. So that was very exciting. And in the mid-90s, there were various groups, Glenn Jeremiah's group in Chicago, that were starting to work with, mostly they were coronary stents of varying magic wall stent and balloon expandable stents that were used to basically, in animal models, evaluate their potential for treating cerebral aneurysms. And there were several groups in France as well as in Buffalo, Istvan Saikura, Lee Gruderman, Ajay Waklu, Barry Lieber, all were involved quite early on in the conceptualization of this kind of endoluminal approach. The first, to my knowledge, the first publication of reporting the use of a stent with coils was Randy Higashida of the group in San Francisco, reporting on the treatment of a fusiform basilar aneurysm. But Pedro Lilick and the Buffalo group also had early cases through the 1990s. That kind of led our interest here at NYU in kind of thinking about like what, instead of using a knockoff from the coronary world, to begin kind of developing a stent exclusively for intracranial use. And there are various challenges for that. One is because of the vascular tortuosity, you need to have a system that is delivered through microcatheters or delivered into the head through a tortuous vasculature. So the design has to be changed. Because the balloons and the balloon expandable stents were typically stiff at that time, we wanted something a little bit more flexible that might be self-expandable. And so a lot of the early device development was done with nickel titanium and other self-expanding metals. But you needed to get the radial force right to sort of optimize it, because initially these were considered to be used for stent-assisted coiling, or like as a sort of analogous to balloon remodeling. And then the vessel, the device had to conform to the vessel wall. And so you needed to have something, enough radial force to seat, to support coiling, to conform to a curvature of the vessel. And you wanted to optimize the cell size depending on what the purpose was, whether to treat in conjunction with coils, to assist coiling, or to act as a standalone device. And this is just the first case that was ever done in the world, and showing it only for anecdotal historical interest. Large ophthalmic aneurysm that we did in Duisburg, Germany. And you can see the devices were kind of difficult to see. Here's the microcatheter tip. There were 4 little platinum markers on bands on the distal part of the stent and the proximal part of the stent. This is the pusher. It just got pushed up through a microcatheter that was in the head. This is a lead guide wire going out. And you could see basically as you begin to unsheath it, the platinum marker bands start to explode, and that tells you that it's opening. Now you can't see the stent in between, so you're only guessing what that looks like. And later in life, I started calling this endoluminal debris, depending on how badly the thing might be deployed. But ideally, in this case, fortunately, went reasonably well. The marker bands opened up nicely. The stent opened up nicely here. We were able to navigate to go back through, and then you would coil it. Now, later, other techniques, parallel coiling with stent deployment, got developed to simplify it. But in general, this was the approach, to put the stent to either, and at some point later, come back and coil the aneurysm. And this is the outcome with this particular case. Now, after about a decade, Max Shapiro was a fellow with me at the time. We evaluated 10 years of early experience with it. And unfortunately, in our field, reporting is like a little heterogeneous. So you sometimes don't get good follow-up. It's all self-adjudicated. But this is basically what we were able to make out of it. And although this technique was mostly applied to more complex aneurysms, so you might expect the outcomes to be a little different than just coiling alone, where it's many times used in small neck aneurysms. occasionally, what we found was that of the results where there was follow-up angiography and it was reported in some understandable fashion, there was about a 61% long-term occlusion rate. Now, there were a couple of issues with the early laser cut stents. Firstly, you can only deliver a certain amount of metal and you're limited by basically geometry. So as that device just opens up, it's going to, the larger it gets, the less surface area metal it has. So you're limited. Now you can do some tricks. You can oversize the stent, and this is just a neuroform. We take a 4.5 millimeter device and we put it in a vessel of different size, and basically you can see that you get different amounts of coverage depending on its oversizing or not. So the second thing is, usually when these were evaluated in models, they were kind of gentle curves like this to kind of illustrate the point. But you can see the open cell structure of the neuroform, and then later with the enterprise with closed cell structure, you end up with devices that look like this. When it comes to applying it to the curvature intracranially, like a cavernous or the carotid siphon here, you're going to have a problem because it's a much more aggressive degree of curvature. And the group in Houston at the time evaluated that very thoroughly, and much to our chagrin, showed a lot of kind of misapplication, misapposition. The picket fence of the open cell structure, and then the folding tendency of the closed cell structure when it gets around curves of sort of physiologic relevance. So then the question came, if we're going to have stents act as standalone devices, what are we going to do? And some of the early development basically was try to either, like the stent grafts of the aorta, cover them, or make them with like some sort of polymer membrane over the neuroform or whatever device you're using. There were a lot of problems with this. Firstly, intracranially, a closed stent gets into a lot of issues in terms of perforator injuries and that sort of thing. So they're eloquent vessels that have to stay open. We can't just like coat them or cover them. Second thing is endo leaks in the head can be a little bit more treacherous than perhaps in the body where they were already known. And with this kind of design, many times we have difficulty as they go through microcatheter keeping this adherent. They have to be attaching them to the backbone of the stent. Gets to be a little problematic. Now you could roll a stent. So instead of just having it self-open, you can have like a stent that unrolls and so try to deliver more. But usually when you roll too many layers of roll, you end up stiffening the device and making it very difficult to deliver. So ultimately, we settled on braided metal stents. And if you look at cross-flow diverters, they're almost uniformly of this design, where you essentially weave a stent so you can have a lot of metal extended over an increased length. And then as it opens up, it shortens, and that delivers more metal to the surface of the vessel. And so this is ultimately what we've worked on and developed here, the pipeline. And this is just showing it. They tend to be very flexible. And the pipeline's not unique in this. There are all the devices have more or less, although vary a little bit in properties, they have similar principles. And you can see you can stretch it out. And then as it shortens and recovers, it delivers that metal to the surface there. Now, there are a couple of important things to really understand before you get into the use of this. And I think it's really incumbent on the operator to kind of learn about the tools so they can begin to apply it. There's nothing magical about flow diversion. It's about understanding the properties of the tool and where it can be applied and how to apply it. So there's an art to that. Now Max and I did a lot of work on initially with pipeline, but all of these braided stents conform to this because they basically have a rhomboidal, like a sliding cell structure. And so if you deploy a device in there's a relationship that the device will have to the diameter of a vessel wall that you're deploying it in. And so that ratio of the stent diameter at nominal to the vessel diameter determines the coverage, and it typically is a parabolic kind of relationship where nominal would be some on this 375 stent here, Nominal would be somewhere here. This is supernominal. And then it reaches a minimum at some level, typically about like 25, 30% oversized. And then it begins to recover as you constrain it further. You come up the other side of the parabola, and the diamonds get elongated instead of short. And so this is it. The second consequence, though, isn't just coverage. It's not just metal surface area that you're giving. The braided stents tend to have their maximum radial force at nominal, and so, or supernominal. As they get oversized, the radial force rapidly falls off, which I think begins to explain some situations where you have delayed stenosis, kind of a circumferential strangulation of the vessel, where the vessel wall just kind of crushes down on the stent because the stent is at a suboptimal radial force where it's dramatically oversized. And typically one sees that when you're addressing a vessel of changing diameter, an aneurysm on a vessel of changing diameter, and you've used a single oversized stent. So there are ways you can get around that. You can put multiple stents, you can overlap stents, you can kind of create constructs of different diameter stents to sort of like pair up as you come down into the larger segment of the vessel. The other thing that we have to concern ourselves with in flow diversion for cerebral aneurysms is what we call the effective treatment porosity. And that's a porosity defined so to essentially enable healing over an aneurysm. So where you have vortical flow in an aneurysm, the device essentially uncouples momentum, causes a stagnation or a slowing of flow that leads to thrombosis and then overgrowth of the stent construct with an intima. Where you have runoff, it sometimes helps us. We don't want to close the adjacent perforators that we're covering. And it turns out that continued laminar runoff into a vessel somehow inhibits the overgrowth, the rapid overgrowth of the device. And these are just some pictures from the animal experiments that Dave Kalmus did for us when Pipeline was being developed by Chestnut, just illustrating that principle, where you have a sac of an aneurysm, the vortical flow leads to thrombosis. It does disrupt flow and enough that you get thrombosis and then overgrowth of that neck with intima. But where you have a runoff into a vessel, the intimal overgrowth appears to be inhibited to some degree. So just kind of historically going over a couple of the cases. This is one of the first cases we did in Buenos Aires. We have a dural cave aneurysm, single device was used here. And this is basically 6 months later, you have this kind of result. All of the initial acceptance of this methodology was done on 2 primary studies, then supported by a registry and also meta-analysis subsequent to the device's introduction. So just historically, it's important to really kind of drill down and understand these 2 trials. The PETA trial, which was the first one leading to CE marking in Europe, was a multi-center prospective single-arm trial. The PUFS trial, which led to FDA clearance in the US, again, a multi-center prospective single-arm trial, paired against a historic control. So they weren't randomized. And the reason for that was essentially that the aneurysms that the FDA found acceptable for trialing really had no acceptable alternative therapy. They just were all very large aneurysms, all wide-necked aneurysms. And the outcome ended up being, you can see the 18 millimeter average size, 8.5, but roughly neck size. The other important thing to understand about PUFs is that there were 2 elements to it. Firstly, the device had to be shown effectiveness, and that was predetermined. It was predetermined that they had to basically be statistically greater than 1 standard deviation of the mean outcome reported in historical controls. And then the safety, it had to be statistically less than the mean for safety of those trials. Now, the other interesting thing about it was that basically in PUFs, it was a binary outcome. So we didn't have a grading system. I mean, we used a grading system anecdotally, but in terms of effectiveness outcome, there was a binary outcome. It either was closed or it wasn't closed, which is very unique for endovascular experiences, endovascular trials. So it either closed or not. And this is just an example of an aneurysm that was treated at 6 months. There was a teeny little bit left. So that was a treatment failure, even though at 1 year, the aneurysm is closed. If you had to use additional devices like coils, in this particular case that I did here at NYU, I couldn't get past the aneurysm. So I put a couple of coils, and the next thing I knew, I had coils in the aneurysm, and I just went ahead and treated it. This was also a treatment failure, even though the outcome was occlusion, because we used adjunctive devices. So it was a very rigorous trial. All of the aneurysms that I mentioned were very complex. Here's a large ophthalmic. You could say it's an ophthalmic. It's really paraophthalmic. It has a very broad neck, involves the paraclinoid segment, the paraophthalmic segment. It's large, wide neck. This is the outcome at 6 months. So again, I think, fusiform aneurysm in the petrous segment. I don't know, other than deconstructing, any other way to treat this. This is the result at 6 months. And so I think most operators in experiencing this, again, another large ophthalmic segment aneurysm, 6 months later, vessel looks new again. And so this kind of psychologically for the operator, I think, creates an appetite for this outcome. It's sort of the wow moment that Chris Moran used to talk about. That is quite impressive. And especially when you're used to treating those kinds of complex aneurysms with coiling, you never expect really to see that sort of result. Even surgically clipping them can be critical. PUFs went on for a 5-year follow-up. So we have data that went through 5 years. There was extraordinarily good follow-up. So complete occlusion was in the 90% range. Again, if you didn't show up for your angio, or in this case, you died or you withdrew, you were counted as a treatment failure. So if there was no angiographic follow-up, it failed. And then, of course, where there was a residual demonstrated, that was also considered a failure. Every single patient was followed, so we'd know which ones improved between 1 year, 3 year, 5 year, all of this kind of stuff. Since that time, there have been a number of trials using pipeline primarily, but also other devices as they came to the market, SAFE for the FRED device, SENT for SURPASS. The PARROT study uses a Chinese stent tube bridge, and it's a unique trial in that it was randomized to stent-assisted coiling. So it compared to that. All of these experiences basically confirmed more or less what was evident in PUFs, that the methodology was highly effective at treating these aneurysms. Premier was used to extend it to a slightly smaller subset because people by that time had already started using it off-label to address small aneurysms. So there was a lot of excitement. This confirmed it. And I think that it's important to think about like the empiric and the investigative support for the device. But I think more or less, you can also speak to sort of an evolutionary process. When devices like this come available in our field, they're usually adopted because interventionalists tend to be somewhat interested in innovation. But quite quickly, there's a tremendous natural selection and pressure from the operators. And so when things don't work, they're quite quick to abandon it. So the fact that it has continued to build, in my mind, I think from an evolutionary standpoint, is suggestive that it's become more and more accepted, and it slowly wins the war of treating aneurysms. Now, we can address what the mechanism of action has been. A lot of work is done on this. Essentially distills down to two things, two categories of activity. We have the hemodynamic effects, and Barry Lieber and the guys at Buffalo did a lot of work in the early days examining, sort of describing how the devices uncouple momentum exchange. I think it's an elegant description of the sort of hemodynamic effects of these devices. That leads to a thrombosis of the aneurysm, and then that organizes the intra-aneurysmal thrombus, allows the overgrowth of intima. And then there's a bioinductive event, and there's a little bit known about that, whether it's the devices became seeded with circulating stem cells that basically cover an intima, or it grows in from the side, the margins of the aneurysm. That is still being worked out, but it's important to understand that for cure, you have to have this intimal overgrowth of the aneurysm neck and the normalization. So this is just a case that kind of illustrates a couple of these points. It's one of the early cases that was done here in the US. Patient comes in with a third nerve palsy, has a large cavernous segment aneurysm. This is the device being deployed here. It basically initially has, this is serial angiogram. You can see the hemodynamic effect. So you're slowing circulation within the aneurysm. The exchange across the stent has changed. It's become more diffusion weighted from convective related. And then you have this stagnation, which leads by Virchow's principles to thrombosis. And this is the result that you see after 6 months, basically, where essentially you've reconstructed that vessel. It looks perfect, it looks good, and the aneurysm is gone. More importantly, that we discovered with time is that the mass effect of the aneurysm, shown on the the MRI scan, disappears. And so basically the mass is absorbed once the aneurysm, the thrombus in the aneurysm is separated from the flowing blood in the vessel. And there's some more exotic, this is one of the Puff's cases, examples of this. Here you have a mass aneurysm, tremendous mass effect. There's stenosis of the vessel coming into the aneurysm. And this is the 6-month result. Not only is the mass effect gone, but the vessel has normalized itself. And so that was just tremendously exciting, and I think sold the technology. So there's still a number of areas of active inquiry. The number of devices is still debatable. Some types of devices were developed hoping to kind of change it to a single one and done kind of experience. I tend to like the idea of the multi-stent construct to kind of customize the devices to each anatomy, all the anatomic circumstances, and the aneurysm necks and things like that. And so we've done a lot of work looking at the consequences of that and how to optimally overlap stents to use shorter devices and all of these kinds of things. But it's still kind of debatable. Antiplatelet therapy, that has evolved. Fortunately, we measure now. There are many more drugs available now. We can customize it to the patient. Some people are hyper responders, some are less responsive. And I think with that improvement, there has been basically a reduction in the complications that we saw early on, particularly with hemorrhages in the brain and these sorts of things, but also with inadvertent thrombosis of the stent construct. So that's all been good. It has improved the safety of the device. And now devices are coming with different coatings, which I think further improves it. Whether or not you couple it with adjunctive coiling, I think there's a number of strategies that need to be discussed, and we can look into that. And then I want to kind of, with a couple of cases, touch on strategic vascular remodeling, because I think that was one of the unexpected findings with devices. They were developed to try to keep perforators and things open, but with time, you can have closing of vessels, and that can be done strategically and asymptomatically. And so then you can customize, you can develop types of therapy for unique aneurysms that incorporate that into the strategy. Then it's a use in small aneurysms. It's definitely sort of growing the boundaries of what we use. Acutely ruptured aneurysms, distal aneurysms, posterior circulation aneurysms, all of this. There are revelations along the way. As I mentioned, mass effect tends to be reduced. The devices over time can be used to induce cerebral vascular rearrangement, and that can be a very important therapeutic aim. Obviously, the devices, other supporting devices have been developed, which have dramatically improved our ability to treat a variety of aneurysms. There's also, I think, the better utilization of improved imaging techniques, which basically improve our ability to properly deploy the devices. And then there a lot of insight into, they bring a lot of insight into the treatment failures. So just to get started with a couple of interesting cases, this was a case of a large aneurysm coming in with a little mass effect, 59-year-old lady with recent onset of crescendo headaches. No history of migraines previously, neurologic exam is normal. So she was found that came into a very prominent center. They did a nice angiographic workup. And you can see the problem here. There's a very complex choroidal segment aneurysm, or distal ICA aneurysm. Circumferentially involves the vessel wall, but there's also the choroidal artery, which comes unusually from the domini aneurysm. So it basically has grown through the choroidal segment to involve the choroidal artery itself. So clipping was kind of deferred. The thought of coiling this and acutely closing this vessel, I think, was decided against. And so ultimately, the patient was sent for flow diversion. And the idea is try to develop a construct to slowly change this this circulation here. Now, remember, the anterior choroidal has a number of collaterals, a posterolateral choroidal, but also from lenticular striate, as you know from Moya Moya. The choroidal to lenticular striate circuit is actively develops with time as need develops. So we started this off with placing 3 stents, kind of aggressively covering the choroidal segment, and then keeping the patient anticoagulated plus on antiplatelets for a few weeks. And basically, this was the immediate aftermath. You see the stagnation. I would just want to draw your attention to the choroidal here. It's this kind of gull wing little vessel as we come. This is basically a few months later. She comes back. Now notice, I just want to take you back. The A1 segment is filling at this time. We extended the stent construct through the bifurcation. So now what has changed is this is no longer filling antegrade. It fills from the other side, though. So there's been a shift in the supply of the right ACA that is induced by having the pipeline across the bifurcation. However, the aneurysm is gone, but this little gull wing vessel is still there. And just to compare them, here it is before, here it is after. Now, though, it fills from a medial lenticular striate down through this little network and comprises it. So the choroidal is preserved through collaterals. We've rearranged the circle of Willis, and the mass effect of the aneurysm has disappeared. And so it's a cure. Beyond PITA and cuffs, where do we use this? Well, early on, people began to say, okay, and understand that if it was going to be effective in large, complex aneurysms, it certainly is going to be effective in small ones. And so there was like a lot of sentiment to kind of extend the application of the tool. And so a lot of off-label devices, until Premier got it extended, came into being, and also different locations that were not under FDA formal clearance. So one of the classic sites, obvious sites, is ACOM aneurysms. And so basically, this is a small ACOM aneurysm. It's a lady that has a family history of aneurysm of subarachnoid hemorrhage, so she was quite anxious to be treated. And when we did the 3D, you can actually see a small little blister off the back of the aneurysm. So we take, basically, to access this, we come up with the 57. Now, there are a lot of new devices, distal access catheters and things, that make this quite easy. There's a new set of guide wires that make it quite easy to take a 27. You can go with a 24 or 18 Aristotle, come up with a microcatheter. And then we just deploy the stent through here. And this is what it looks like afterward. Now, on this side, I used a Vantage. I went to the other side and used a Pipeline Flex Shield, just so I could have a comparison on their behavior. I actually made a little mistake here. I deployed this one a little too proximally. So after doing this set of imaging, I went back through and put a second device just so that I could make sure this wasn't going to fall back into the aneurysm. But this is what it looked like initially. And actually, this is just kind of interesting to compare the two of them. After discussing with a lot of my colleagues, I sort of prefer the open cell structure or opacification of the Pipeline Flex, because especially if you're putting multiple devices, you can see it a little easier than this kind of like cloud of opacification with the Vantage. So this is what she looks like essentially 6 months later. You can see from the right side, left side. Both sides look good. This is the construct of the pipeline. You can see the imaging that we have these days is much better. Now, do we always do that? Not always, no. You have to remember there are other techniques. You don't want to like just automatically go to pipeline. I think it's very effective for many aneurysms, but in situations, and this is like not quite extreme, but sometimes you'll have an atretic A1 on one side. This is just a hypoplastic A1, slightly more prominent A1 here. But in an atretic situation, I usually don't like to just go for jailing unless it becomes necessary, the contralateral ACA. So in this particular case, there's a new set of flow diversion types devices. These endovascular flow diversion devices, Contour and Webb, are the classic ones, but others are coming out soon. And you see it's a complex aneurysm, multi-lobular, kind of large aneurysm, wide neck, kind of extends into the ACOM area. And this one you can easily address with a Webb. You see you get this nice flow diversion effect right away. You can kind of do all the fancy imaging that you want to kind of make it positioned properly. And imaging is really increased and improved our methodology. And here's 6 months later, you have a very nice result with this endovascular flow diversion as opposed to, and you can see the device here, how it sits down in the neck, and that would be effect. Now, if it's not seated properly, if it's not sized properly, unlike the devices that are deployed in the lumen of the vessel, these can develop side leaks and recanalizations. So you have to be a little bit careful, and I think the imaging drives that. Distal anterior cerebral artery aneurysms. This is certainly, if you can get your microcatheter out here, which becomes increasingly easy to do, and now with new generations of flow diversion devices that go through 017 microcatheters, this becomes quite easy. And these types of aneurysms really respond nicely to devices like the pipeline. And so basically here it is, you're deploying the device just sits in the pericallosal, you have immediate stagnation of contrast right there, and then 6 months later, this is what it looks like. So very easy to do these kinds of cases. They go very quickly. This was a physician that had a transient third nerve palsy, got imaged out the wazoo. I think she was a radiologist. So she had all kinds of imaging, came up with this small little aneurysm and then wanted it treated. So this kind of an aneurysm, you could say, well, okay, there are a couple things. You could open your head, clip this. I think coiling this would be kind of difficult. It's very small. And then when we did the 3D, you see that not only there is that aneurysm, but there's an adjacent smaller aneurysm that was right there. And so I think that's impossible to coil. Again, it's a fetal type. There's no P1 here to speak of. So we take this. This is the microcatheterization. It's nicely supported here. I think this was a Sophia or something. Yeah, 6 French Sophia. Distal access catheter supporting you right at the base. Bring your 027 in here. This is just a pipeline flex shield put. Immediately, you see the stagnation in the larger of the two aneurysms. And this is what it looks like 6 months later. So you have, or 10 months later, basically you have recanalization, reconstruction of that vessel, curing of the aneurysms. A similar lady with a family history of subarachnoid hemorrhage found to have this very tiny PCOM aneurysm. Initially, we were kind of following it, but PCOM aneurysms are perhaps of the anterior circulation aneurysm, maybe slightly riskier. She was just an emotional mess. And so after a couple of years, insisted on having this thing treated. Now, I didn't know how I wanted to do this. There's a lot of issues when you have large PCOM treating these aneurysms. But I think that definitely the device has a place for it. Occasionally, in some larger aneurysms, I'll put a pipeline here in the ICA and then come retrograde and coil the aneurysm. And that's what I was prepared to do here. So we went first with a SL10 up the vertebral basilar system, just to kind of put it, the microcatheter tip right here. Then we deployed a pipeline. And after I kind of evaluated, I chickened out and decided not to coil the aneurysm. So we always like to make sure that the stent is fully embedded. So I'll either use a balloon or I'll take a J wire up through and open up the stent. A lot of the aneurysm failures with flow diversion devices have to do with, is the device fully embedded in the parent vessel. And so I think it's very important to go the extra step. And now with cone beam CT capabilities, you can be you can really have a lot of insight into how is that device placed within the vessel. Is there any potential for endo leak or other kinds of issue? And so this is basically the immediate aftermath of the device. We decided not to. Here she comes back for follow-up, and the aneurysm is gone, but notice that the PCA is smaller. It's not completely gone. The PCA is smaller. She does have a P1, so that distal PCA is going to ultimately be supplied completely by that. But this has, as the aneurysm shrunk, the vessel also shrunk. So the two of them go down. And that's just, again, another example of how the device can remodel flow to the demand of the cerebral territory, the vascular territory. Now, there's been a lot of discussion about, like, should these devices be used in cases of fetal PCOMs? And I'm going to just make a case for the possibility of doing that, even though, like, this is a very experienced group here that initially kind of evaluated their early experience and decided that this was perhaps less ill-advised. So just to show one approach to managing this kind of a case. Referencing back to the case I just showed where the device caused the PCOM to change in size. Now here is a partially thrombosed aneurysm, PCOM aneurysm. This is the 3D. You see it's a little irregular here. Kind of circumferentially involves the origin of the PCOM coming off the ICA. It basically supplies the whole PCA territory. Here's the vert. There's no obvious angiographic PCA, but I know that there embryologically is some capillary there that can grow. So there's going to be something there that can grow up. So the way we're going to approach this aneurysm is we're going to put two devices right up front across this PCOM segment. We're going to stagger them so that across the choroidal is one device. Across the PCOM is going to be, we're going to overlap them. So the first one comes just here. The second one begins just proximal to the choroidal and then comes over. So you get double overlap of the device, of the PCOM. And so this is immediately afterward. You see a little stagnation, basically still runoff going into the PCA. 3 months later, we bring her back because I'm thinking of a stage procedure, and this is what it looks like. There still is some antegrade flow. Aneurysm hasn't changed, but there is now from the basilar basically a little supply to the PCA. So we go ahead and add one more device. And this is the, at the time post-procedure, a little bit of filling there, and then this bird filling like that. And then she comes back 3 months later for follow-up. I was going to put another stent if I had to, but aneurysm is now closed. PCA is filling from the vert, and there is no infarct. So that's how you can deliberately start to remodel. Now, do we always do that? No. So this is a patient that had a rupture, recovered, wasn't treated, and then came, I think, about 6 months after rupture, made a full recovery for treating. Now, this is kind of a fragile aneurysm in my mind. So I wanted like coil and stent. So it's not quite a fetal PCOM. There's obviously some supply going into the posterior circulation through a small P1, but there's an obvious P1 that could support this. So we're going to put a pipeline and we're going to also coil. And so basically this is the result of that. And so you see here, no longer is the PCOM filling, it's filling from the posterior circulation, but the aneurysm is sufficiently coiled. It's not the densest coil pack. I just put enough coils to kind of like protect the dome and then use the stent to fix the aneurysm. This is a different kind of a case than a posterior circulation case. A 53-year-old gentleman with a acute right third nerve palsy, large mass effect here. This is basically a PCA aneurysm, P2 segment, early P2 segment aneurysm. You can see there's a lot of mass effect from mostly thrombosis separating the P1, the PCA from the superior cerebellar. So only part of it is filling. The rest of it is this mass, and this is the transaxial imaging of it. So we're going to put, I think I overlapped 2 devices here. This was initially what we saw, and basically still a little separation there right after the procedure. And then this is what we start to see here, 1-year follow-up. There's less separation of the aneurysm, and the PCA has been reconstructed. And then this is what it looks like on transaxial imaging. So the mass effect that you saw initially down here on the CT has resolved as that vessel has been reconstructed. This is a slightly different case, more complex, a woman that came in with new onset seizures, and there's like a mass here that's poking into the medial temporal lobe. It's more complex than that. As you can see, there's like a sort of fusiform, unusual segment to this aneurysm. This is what it looks like on the 3D. The P1 into P2 comes here. It really starts involving P2 and then extends into P3 and early P4. It has different components, though. There's a big aneurysmal component in the proximal P2. There's this kind of corkscrew piece in the distal P2, and then around P3, you get this other aneurysmal formation. And this just kind of illustrates it here. It's a little bit windowed a little differently to kind of understand. This is a submental view of the whole thing. So how to approach this? Well, you first want to do a good diagnostic study. So we take a balloon, see, like the way historically this might have been treated is just to do a vessel takedown. And so you blow the balloon up. Her collaterals weren't really fantastic into that territory. So this is the contralateral PCA that's filling across the midline. The balloon's blown up in the distal P1 of the left side. And then in the late phase, you do see a little bit of parietal occipital and some PCA branches coming back, but it kind of was a little delayed for my taste. So we decided to reconstruct this. And we started, I did it in 2 stages. First, addressing that proximal P2 piece. So we did a 5-stent construct overlapping them. I had to go kind of loop to loop through this mass. I used a balloon here to make sure that it's well seated and that it's open fully. And so we took a balloon and kind of like modeled it here. And then I discharged her, brought her back in, I think it was 5 weeks later, to address the more distal part. Now, the corkscrew piece I was going to leave behind, but what was worrying me was this kind of more saccular piece of aneurysm in the distal and sort of the P3 area. I could not access that with a 20-second catheter. So basically I had to go with a 017 microcatheter to get out here, which then limited my choice. At the time they didn't have Silk as the baby. So I had to use I think it was a Elvis Jr. here. And this just kind of shows the access. This is the stent starting to come out. This device tends to be a little flimsier. So you see it's kind of, you have to kind of massage it, going back and forth to get it to open up. As it comes around, it starts to try to kink a little bit there. And then we kind of like finally get it popped open by just massaging the delivery wire with the microcatheter, bringing it in and kind of trying to take it around and just opening it up a bit. So this is the immediate aftermath. You see there's stagnation in that little saccular component. I'm just going to leave this alone. I'm not going to put anything in this part of the vessel here, and just go on. And so this is basically 5-year follow-up that we have with her. Here's the Elvis Jr. out distally. This is the pipeline construct that's going here, and this is what it looks like on the 2D angio, with this corkscrew part in between that's just basic stable on the sense thing. And this is just from the bird, looking at it from the bird. Now, there's still a lot of controversy with using these devices in certain situations, bifurcation. A lot of studying is being done. This is the group in Montreal. They published a lot of like kind of hemodynamic data plus some animal on bifurcation aneurysms. And, I'm not going to attack the validity of these studies. It's all important information to kind of understand the hemodynamic effects of these tools. But I guess my point is that there's something more complex in play. And that goes back to that bioinductive capacity. You can't always predict things based on hemodynamic modeling. And just to prove this point, this is just the nice little bifurcation aneurysm that we're using in their model. But when you come to reality, here's the same aneurysm in a human being, a single device, and basically this is the 6-month follow with that. You can have very good results with this. There's also, the tool also kind of extends our ability to treat aneurysms that were otherwise unaddressable. But you have to go beyond just seeing them as only flow diversion tools. You have to couple different kinds of approaches. Again, it's not a magic wand. The devices are not just put a flow divert in and let it go, let things heal up. No, it has to be, it's a tool, and you have to use the tool properly, and you can use the tool in different ways sometimes. So this was a lady that came in initially with an enlarging, I think she had a third nerve palsy initially. We followed her initially because the aneurysm, as you find out, turns out to be somewhat complex. So initially we were going to just kind of manage her conservatively, just watch it. But then over like a few month period of time, it massively enlarged. So you have this kind of thing. And so this is the angiography of this. I'll just go over this carefully. So you have the basilar, it's coming up here to the terminus. You have a hypoplastic P1 on the right. Superior cerebellar drops off just underneath the aneurysm. The aneurysm has like kind of a fusiform involvement. It involves the P1 segment on the right side, or at least the origin of the P1 segment on the left. And it also extends into the superior cerebellar on the left. So a very complex aneurysm. And I wasn't really sure. We looked at this over a couple of month period of time while it was growing, just to figure out how are we going to treat this. And we finally ultimately came to like a different kind of approach. And so we brought her in, did a lot of angiographic evaluation. This is basically some balloon test occlusion of different parts, but mostly to see if we close the distal basilar, what's going to happen from above. So this is the right side with its kind of dominant PCOM, a reasonably well-sized PCOM on the left, but because it has a large P1 and that's involved with the aneurysm, basically you fill the aneurysm with occlusion of the basilar down into the superior cerebellar segment. So that didn't seem like it was going to be an effective treatment to do some kind of like proximal occlusion. So ultimately, we decided to deconstruct the superior cerebellar. So we did the test occlusion, saw that there was reasonable collateral supply, and took a 5-millimeter pipeline off of antiplatelets, so no antiplatelets, take a short 5-millimeter diameter and deploy it in the proximal superior cerebellar. So it just kind of funnels up. Here's the pipeline. And inside that, we put an MVP, just to kind of fully occlude the vessel. But without antiplatelets, a native pipeline is pretty thrombogenic. So that just kind of helped stabilize it. So this was phase 1, just taking down, deconstructing the superior cerebellum. Now, phase 2 wasn't going to be reconstructing the PCA. What we had in mind was to come and basically reconstruct the basilar terminus into the superior cerebellar. And so we brought her back. By that time, even the remnant had started to grow. So the superior cerebellar is occluded. The P1 is running off from the aneurysm itself. The P1 on the right side is atretic, and this is the superior cerebellar that we're going to build the construct into. So we had to catheterize that. It wasn't the easiest thing. Had to go loop to loop down into the superior cerebellar. I did this with Howard. Howard Reno, my partner, and I were doing this together. So we get this, and we ended up having the 27 microcatheter out there. And we deploy the pipeline after reducing this curve from superior cerebellar into the basilar. And this is more or less what we achieved. This is like an angiogram that was shot a couple days later before we sent her home. You can see already the distal piece of the aneurysm is not filling from the basilar any longer. This is the hardware. The good thing about the hardware is that you can do CT because there are no platinum coils. So the MVP and the pipelines are fairly CTable. And this is basically what she looks like 12 months later. So this is the ICA on the left. You can see it fills down to, the P1 fills retrogradely to this Hirschron, this thalamoperforator that comes off here just past the aneurysm. And so we're still filling that retrogradely, but the aneurysm doesn't fill. And so that is nice. From the right side, you have the dominant PCA that's still the PCOM that fills the PCA. And then the superior cerebellar fills from the basilar, but there's no opacification of the aneurysm. So what happens? This is the initial mass effect. And this, at 6 months before we brought her back for the angio, we already had done the MR at 6 months. And you can see there's resolution of the mass effect. And then just kind of parenthetically, this is the CT immediately after her second stage treatment. You can see there's separation between the 5 millimeter pipeline and the one in the superior cerebellar that over the course of time disappears and the two of them migrate together. So it was just kind of a cute way to show the resolution of mass effect on CT with those internal markers. This is another case of a posterior circulation aneurysm where the device has some utility. And a lot's been published about the use in fusiform aneurysms. I'm not going to show you the most complex one, but this one does have some features that are usually prognostic of less than ideal outcomes. So it's a 25-year-old gentleman that presented with diplopia from a 6th nerve palsy. And this is his MR showing this aneurysm. The aneurysm's here. The complicated thing here was that the ICA arose from the belly of the aneurysm. And usually that's a bad prognostic sign because the runoff in the ICA tends to keep these large fusiform aneurysms alive. So we ended up doing something a little different here. I ended up trying to, I put a large stent within the sac of the aneurysm, a 5 millimeter, and then I built a construct that was a little bit, and to kind of create a little baffle, hopefully to break the pulsation a little bit. And then I used a total of 5 stents. So there's 4 stents inside a single baffle, larger stent. And so this is the initial outcome. So you get an immediate output. I'm just going to point out this curve, this hairpin curve of the ICA. So the ICA is still filling from the aneurysm. It's filling slow. We kept him on some anticoagulant as well as antiplatelet because we didn't want this to close off acutely. And so this is what it initially looks like in the post-CT. You see at the stagnant contrast. It's about a 14.5 millimeter aneurysm cross-sectionally. 3 days later, this is what he looks like. The ICA is still filling. There's this kind of ectatic segment. Here's the loop of the ICA there. So it's basically a channel through thrombus that is just preserved as the runoff continues to grow. Now, what is the consequence of that? Because we always get into this question, is a thrombosed aneurysm a safe aneurysm, or is it your friend, or does that mean it's occluded? And the answer is no, it's not. It's basically just, thrombus is just like it's a gel. It's a different kind of fluid. And so basically he came back 5 weeks later with worsened headaches. We did a CT. You see the aneurysm is now 20 millimeter, a little over, almost 21 millimeters. There's a lot of edema. We debated, this is the angiogram we shot. It's again still filling through this ectatic segment in the aneurysm through the thrombus, and then fills out that loop. So we debated, should we put another stent in there or what to do? But I thought because we had 5 in already, that probably that was going to be sufficient. We just toughed it out, put him on steroids. He did get better. And then 7 months later, symptoms were resolved. You see the mass effect of the aneurysm has dramatically changed, dramatically gone away. And this is his 12-month follow-up angio. Now I show you the left side first, because what I'm showing you here is that you don't have the right ICA filling antegrade any longer. So that has closed. How is it filled? So we go to the left side. And basically through collaterals with the pica, you fill out in a delayed fashion this loop. And so here comes the loop. It comes retrogradely from the right pica. And so that's, again, another example of how we manipulate the circulation. And that, I think, is kind of the next level of utility for these devices, is to kind of rearrange the cerebral circulation to get a therapeutic effect. So the drivers of therapeutic advances, they can kind of be thought of in two terms. One is you have the technological innovations, you have new devices and new materials that are being used. Now the devices are coated, so they're safer, they're more effective, and that's all great. So that's what basically the science, the engineering brings to the table of our field. But what we as practitioners bring, I think, is the art of the practice, how to take a tool and not see it as a magic wand, but it's a tool. And you can use that tool in a variety of ways to get different treatments of many different diseases. We've used these devices to close fistulas and other kinds of things. So the application of the tools is very important, and that's where I think practitioners can contribute meaningfully to the advance of the therapy. It requires, though, a synthesis of a lot of knowledge, familiarity with the tools, obviously, understanding how they can be used, the different ways, but also having insight into their limitations. You want to understand the applied setting, the anatomy, the embryology, like in the fetal pecan aneurysms, understanding like what potential circulation you might be able to take advantage, exploit to get a treatment. And you have to understand the physiology that's involved. And then you also have to practice the technique, and you have to be dedicated to excellence. So all of that is meaningful. All of that's important. We need to understand the therapeutic limitations. You don't want to be completely married to one magic wand. You want to have a portfolio of tools, as I showed you earlier. Sometimes the web is the right answer instead of pipeline. But pipeline can be used in a lot of those settings, so they overlap a little bit. So you want to understand the limitations of the device and the techniques that are involved. And that all leads to improvement, not only in the types of devices used, but also in the technique. Thank you very much.
Yes, thank you so much, Dr. Nelson, for that great talk and, again, evolution of remodeling. I'm going to open up the floor to questions. I see Dr. McDougall continues with us, and some of the fellows are also on.
Yeah, it'd be great. That's so much fun just to see you go through that and relive some of the history. You talk about the art, and I absolutely agree it's an art, and I think we see a lot of people not being anywhere near as thoughtful as you are in this in using the device. How much have you looked or relied upon computer flow modeling and things to sort of shape your decision making?
So
and how much really is art?
Yeah, I guess so on an intellectual basis, I'm always excited in being able to describe the effect of a tool. So I've followed CFD, I've done a lot of things thinking about the tools. And I think that where I find it more interesting is like how that helps you to design a more robust tool. So we have a problem with like opening pressure and opening force and things like that. And I think the more we understand about that, the more we understand the impact of porosity on the hemodynamic factors. But I've never been a real big believer that that was the total. The problem with biologic science, medical science, is that there's so many unknown factors. So, like I'm sure you have with me have lived through a time when high shear stress was bad. Then low shear stress became bad. Then a combination of hemodynamic factors became bad in the way an aneurysm does. But really, we're talking about a big unknown pool of biology and how the biology responds to the physics. And so more or less, I use a lot of just empiric observation of cases, case studies. And I'm not driven so much by a precise CFD value to stop treatment or to go with treatment. In my mind, I always have seen them as endoluminal scaffolds. And so if I don't think I have an adequate scaffolding for the intima to grow over, I continue to put devices. But devices also can be overlapped and used to make a more perfect construct, to make a construct that it conforms better to the anatomy of a vessel that's changing its diameter. And so I think that, you know, that plays a big role in it too. Sometimes you size a tool in a perforator-rich area to get less coverage or to get more coverage. We lately have been studying kind of the opening force of a lot of these tools, primarily motivated since Vantage came out, because we have a sense that the tool actually has a little bit less radial force than the conventional pipeline and pipeline flex. So I can't say that I totally ignore the flow. No, I love the studies. I was an early devotee of Barry Lieber's description of how these devices behave and the hemodynamic effects of them. I just never was a big believer that it was all hemodynamic. I mean, there's a big piece of it, but there's a large biological part that we don't really have a firm grasp over. So I think it's important that the methodology that you're using is robust and as good as you can make it. And to that effect, you know, we are aided now by the vast improvements in the imaging quality. Like so many times now, I used to just kind of routinely take a J wire and just kind of go through. Now, like we really can study, and you can see that a device is not implanted. Where you have overlapping devices, maybe the internal device isn't perfectly opened up. And so you can continue to address it. If you need a balloon, you take a balloon and you do it. But you at least have something that you can visualize that's an endpoint. So I think that with time, the important thing is to get people over the hump of using the tools that are available to try to do the best job possible.
Yeah, my sense is that your threshold for adding a second device, for doing those for that attention to detail in terms of the implantation, I don't know how widespread that is and how much people really are focusing on that art and that you know what I would sort of call the last 10% of doing the procedure right. That you know they put it in, it looks good, they have some stasis, it's a 20-minute case, and next.
Yeah, so I did a lot of proctoring, and I kind of routinely encountered that where people, they want to just put a device, they see the hemodynamic effects, so they want to run away, even if the device is not seated well, and that just sets you up for failure down the road because it allows the possibility of an endo leak to develop, and then addressing that later on becomes more complicated. So there are two things that kind of enabled me to go forward. When I first started using pipeline in the PETA trial, the first half of the cases were done stent-assisted coil. So one device coils. And that was like the model because I wanted to treat people. I didn't want to hurt people. And so with time, I though become like, so instrumental was in PUFs, as you recall. There was neuro-ophthalmologic exams of all the patients. So we had an example of a vessel that we were covering. Many of those cases were covered with multiple stents. And it was remarkable how few complications occurred with covering this. So I became a little bit more comfortable with covering branch vessels with multiple constructs. Had we had problems, then I would have backed off and I would be sort of one and done kind of guy. But that sort of confirmed to me that it was possible to put more devices. And then later, as I found that you could sort of rearrange the circulation, I became more interested in that. The second thing is with, you know, I think what many people, perhaps because they don't use multiple stent constructs, what they fail to understand, the hardest stent to put is the first stent. Getting access to past the aneurysm, placing that, sizing that first stent, Once you have a stent in place, putting the second stent is not a piece of cake, never is, but it's an order of magnitude easier. And so I think the time to do that is up front. And I am motivated mostly because of the heritage of coils. In my practice, psychologically, I always had a hard time explaining to a patient why I put you through this procedure and you're not cured. And so now we have to go again. And so much of my work in assist devices, I was very early aggressive with balloons, balloon remodeling. Every case, it was a balloon remodeling case, was to try to get a better result, to reduce the number of people coming back to me that were untreated. And so that still, I think, is one of the things that motivates me. I just really have a very low threshold for cases that fail. And so I want to, in the upfront initial stage, try to cure the aneurysm.
To follow up on that thought, I mean, if you stay in one place for a long time, which is why I move a lot, you do require a stable of the, again, 10%ers. If you have 90% cure rate, you've got this 10% of people that you end up following for a long time. What are your sort of thoughts? Like, in what I was reassured recently by some of my former colleagues, publishing Alex Coons's follow-up and the lack of hemorrhages in these patients who have residual aneurysm filling, long term. And so what are you telling patients in terms of their, are they protected? Are they better off? When you've got that aneurysm that still fills 5 years after it's been pipelined.
Yeah, I guess I'm a little Paleolithic on some of this, but as you know, in flow diversion, first of all, like Puffs had a binary scale. We were interested in, is it closed or not closed? Because that's, in my mind, I like to work in a binary system. I'd always was irritated by like the endless grading scales for coiled aneurysms because there's like, what's meaningful? And so the good news in ISAT initially was that even the partially coiled aneurysms seemed to be protected. Now, with time, that kind of got rolled back a teeny bit because there were delayed ruptures and recanalized aneurysms. And so I guess I tend to go like along with philosophically along Karl Popper and falsifiability. So if I have an example of a recanalized coiled aneurysm that ruptured on me, which I do, now I know it's possible. So then, yes, it's important to get a handle statistically on what the likelihood is. And I still am hopeful that it's less likely to act up and rupture. But I know that it can't be ignored. Same with the mass effect. I showed a couple of the big aneurysms, and we all have cases like this of like aneurysms that just get away, they're growing, patients become worse. And so I'm not so accepting. Now, in the grading of flow diversion effects and flow diversion outcomes, as you know, there are now grading systems. And very good friends of mine are promoting the idea that an aneurysm can be maybe protected, safer, if it just shrinks a little bit or if it stops growing. And I don't know what the answer is. I mean, I'd like to believe that that's true. I'd like to believe that if you put like some kind of an aneurysm, as some kind of like flow diversion covering, even if the aneurysm doesn't shrink to completion, it maybe has a lower likelihood of rupture. And so we'll see. I do know that some of them do rupture though. And I know that from especially treating complex basilar aneurysms, that even aneurysms that angiographically look perfectly cured, but we know that they're just thrombose, they can have a very negative outcome prognostically. So I'm conservative. I guess I'm conservative. I don't want to immediately buy into like a partially treated aneurysm is okay. But that there probably is some truth to that.
I want to just sort of comment, as you went through sort of the history leading up to this, it is always fun later in life to have lived through some history and to see what the attitude of that this was inevitable, that this was, so obvious in retrospect, I guess you would say, and what you accomplished, and you showed some of our littered history of devices that came and went very quickly. And I could think of the matrix coil, and the matrix coil was inevitable and obvious and was going to change the world, and aneurysms were cured. And obviously that didn't work out. So it is something I really think people need to think about when they're embarking on something new and a new adventure like this, and how precarious it was for you at the beginning, and for all of us, and the wonderful surprises we saw. You mentioned, for example, the fact that we didn't blind anybody in the PUFS trial. All of these things now seem obvious, and we're very comfortable and confident about, but none of that was inevitable. None of that was. It was a very very high stakes, high risk adventure, and an amazing journey.
Yeah, I mean, it's gratifying, and I mean, it's also fun talking with you because you've been involved in many of these kind of seminal changes in the field. But I think, like, I always approach with the skepticism of what I'm doing. When I was here with Alex and we were first coiling back in the early 90s, like, he was gung-ho, he really pushing it. I always was like, well, yeah, but this is like, why are 10% of the patients having thromboembolic issues? Or I was always a little, I guess, pessimistic. He used to call me pessimistic. But it's the pessimism that drove me to look for something, be interested in having a better approach. Again, though, when I got into the flow diversion devices, I still kind of, I always saw them as more like just kind of lower porosity, higher porosity devices. I still was nervous about like using them as standalone because I didn't want to have a patient treated this way and then like it doesn't work. Okay. So we were coiling, and it was Isvan Saikura that convinced me to let's just leave this one because it looks like it's gonna, it's so stagnant. And so that was a kind of a revelation in the course of doing the PETA trial. So that's why PETA started out being a sort of stent-assisted coiling, and then it kind of became stent. And then once we saw that, it gave us the confidence to get into PUFS. But like the matrix, it's interesting that you bring that up because it's not just that, okay, we have like a modification of a coil that we then hope is going to be better. But there was a whole science on that developed around that concept, like that it's going to have like, there's going to be more scarring. There's going to be like this kind of development or evolution of the thrombus into scar tissue, and that's going to make it more effective. And people went along with that for a long time until your trial kind of.
Yeah, well, I mean, even
and then the Cerocyte was the same thing. They were pursuing Cerocyte and Hydro too. Like more space occupying stuff was going to be the key.
Well, there was some truth to all those things. I mean, it wasn't it wasn't fantasy, but it was it just wasn't enough. It just wasn't enough.
Just like, and I guess back to your initial point about the hemodynamics, that's absolutely true about these devices. Is that the critical feature though? And that's what I don't have an answer for. But like the thing, I lately have kind of gotten interested in kind of casting it, not to become a social Darwinist, but there is something vaguely similar to evolution in the sense that something comes out, it's a change, and there's a selection pressure that the operators bring to the table. Venous stenting for MS, that was another one that, like, all these ideas. And it was widely embraced and then abandoned. But other things like kypho, like stood the test of time, and then utility was demonstrated, and finally the community embraces, despite a trial that kind of suggested it was no different than placebo. So yeah, the science is not like physics.
It is reassuring to me that there's still some art to it, and you know, you are one of the great artists, and I've really enjoyed spending some time with you. The shrug, I love it.
Great. Actually, that's the
It's
best part of it, is meeting all the fun people that, yeah.
well, it's been great spending time with you. I've kept you long past when we said we would. Really enjoyed it, and thanks so much for being here this morning. I hope we get to meet again in person soon.
Yeah, no, it's great. I was hoping while you were in Baltimore, I might pop down, but you
That
the
was a
West Coast was
difficult
fun.
COVID time for us.
Oh my God. But you know, it's illuminating. In the same way, when I got into medical school, it was the AIDS crisis while I was a student, and you know, sort of like bookended my medical career with two crises, two pandemics. All right. Well, thank you so much for inviting me. It's wonderful to see you again, and it looks like your group is super around you.
We have a nice group here. I really enjoy it.
Production capacity here is just tremendous. I'll have to talk to Max about buffing banana and neuroangiography.org.
Well,
Okay.
come visit sometime. And again, thanks so much. Wonderful seeing you, and be well.
Okay. Fantastic. Good seeing you. Bye.
Bye now.
Thank you, guys.
Thank you.